So talking about D-dimers, a lot of patients come up with D-dimer values. Please remember it's a very sensitive assay and it is mainly responsible for the OPD setting or the emergency department setting. And in a patient who has low or intermediate probability of PE, or in which we have a very unlikely PE. So then you can do a D-dimer, and if the D-dimer is negative, you can safely exclude the PE. Most of the patient uh, in the OPD or in the low clinical probability profile, we do this. But if your patient has got a very high probability of PE, then you don't have to do a D-dimer because a normal result will not exclude a PE. So this is the important point which you have to remember. So D-dimer testing is only recommended for a low or intermediate probability of PE. And various cutoffs are available, which are age adjusted. So there is a chart available. You can look at that. So the next test was CT pulmonary angiography. Please remember that CT venography is not a substitute for angiography. And in this patient, you can see there is a bilateral pulmonary embolism in the major pulmonary artery and the subsegmental arteries, both right and left. You can see a filling defect in the right and the left major pulmonary artery. So what are the types of imaging you can do? See, CTPA is the gold standard. It has got excellent accuracy. And if you are doing a CT, you can look at the lung also. So the alternative diagnosis, for example, if there is a pneumonia, if there is a COPD, emphysema, if there is a cardiac failure, then you can all have an idea after doing a CT. And it is inconclusive only in 3 to 5% of the patients. Definitely, there is a contrast involved. So renal failure patients, you have to be very cautious. And VQ scan is also available, but remember that there's a lot of inter-observer variability and it is inconclusive in 50% of the cases. So routinely we don't do VQ scans unless there's a contraindication for CTPA. Then the conventional pulmonary angiography is the gold standard, but it is again an invasive test. The person has to go to the angiography room and which may not be possible. VQ SPECT is a latest technology which has got the lowest non-diagnostic rate, and radiation is also less. So you can also use this if you have availability of VQ SPECT, but in general we do CTPA for all the patients. And MR angiography is not recommended to rule out PE. Please remember it. So as I told you, for assessment of severity of pulmonary embolism, we have got the pulmonary embolism severity index, and there are also other biomarkers. First you do clinical, then imaging and biomarkers. So once the patient comes, you do the pulmonary embolism severity, and then you can do the imaging by looking at the echo or CT scan. And finally, there are markers of myocardial injury or RV dysfunction, which are known as biomarkers. You can do that. And this is the score. As I told you, pulmonary embolism severity index, and the points are given. And in our patient, you can see we have given the points, and this is how the score came. And our pulmonary embolism severity index score was 4. So this patient was an intermediate risk, as I told you, and you can predict the mortality risk also by using this score. So this is a score which is easily available online. Also, you can do it by sitting in on your laptop or on your mobile. You can do the scoring, and it is very important that you at least understand once the patient is with you that what are the risk factors and how to prognosticate the family, because pulmonary embolism patients can deteriorate very fast. So in this patient, the PESI was 162, which is more than 125 points, and the mortality risk is 10 to 25%. So this is very important that you prognosticate the patient. And then coming to imaging, You can do a echo or a CT thorax. The echo, the most important sign is the dilated RA-RV. And the CT thorax, as I told you, you can see embolism, or if you're doing a CT, you can also look at the heart. Sometimes you can see straightening or blowing of the IVS, interventricular septum, to the left. So these are just guides. They are not diagnostic, but definitely you can assess the patient bedside echo. CT thorax sometimes may not be possible in an unstable patient, but definitely if the patient is presented to the ER and the patient has got blood pressure stability, you can do a CT. So our patient underwent a echo and a compression ultrasound, and the Doppler was negative. There was no embolism, no clot, DVT, and the echo showed a EF of 55%. There's a severe tricuspid regurgitation and a severe pulmonary artery hypertension. And you can see in this patient, the RA-RV is slightly dilated in the CT scan, and the interventricular septum is straight. So this was suggestive of a right ventricular strain. And then we send the biomarkers. Please remember that RV dysfunction, you can send a NT-proBNP or a BNP, and values are there. And also remember that proBNP is raised in both RV and LP dysfunction. But if you are suspecting a RV dysfunction, you can send a proBNP. Myocardial necrosis, you can look at the troponins and troponin I or troponin T elevation, CPK-MB. In our patient, the NT-proBNP was 3,760. So definitely there were signs of RV dysfunction, and troponins were negative, so there was no myocardial necrosis. So because this is important, why I am telling you all this, that apart from hypotension, you have to grade the patient into pulmonary embolism severity index, and then you have to look at the echo, CT scan, and the biomarkers. Then only you will be able to assess the mortality risk. If all the four are present, the patient has got a very high mortality, which means the patient is having shock or the severity is more than 1. The RA-RV are dilated and the biomarkers are positive. So this is a very high risk patient with a very high mortality.